Hi, good evening, everyone. Welcome to the Yashoda webinar, which is organized by SEMIA as well as supported. Now, today we have an interesting topic, a case of acute flaccid paralysis by Dr. Rushi and Patel. He actually holds an MBBS and MD in emergency medicine in from NHL Medical College, Ahmedabad. After that, he did IDCCM from Dinanath, Pune. Currently, he serves as an assistant professor in Department of Emergency Medicine at GCS Medical College, Ahmedabad, Gujarat. So, Dr. Patel is he has actively involved in managing acute medical and trauma emergencies, mentoring medical students. Currently, with a lot of experience, let's bring him to the Yashoda webinar and welcome him. Welcome, Dr. Rishi Patel. I think you can take over regarding your presentation.
Yeah. So thank you so much, Harish, Dr. Harish. લેબમાંથી આવ્યા છો? મેં બનાવીને રાખ્યું છે ચિઠ્ઠી. સંધ્યાબેનને કહેજો ને ખાલી તમને આપી દેશે. Hello. So thank you, Dr. Harish, for my introduction. And I'm very thankful to Society of Emergency Medicine India and Yashoda Hospital. And I'm pleasant to present one of the case that is one of the brainstorming and can bring some of the crucial aspect while managing the emergency cases. So thank you, Dr. Harish, as a moderator. Thank you, Dr. Srinath sir. Thank you, Dr. Sravani. Thank you, Dr. Kondle Raghu. Thank you, Dr. Malaya Mishra, and a special thank to Dr. Sree Sowjanya, madam. So today is the Teachers Day. So to the all my mentors, teachers, and student also, because learning is a continuous process. So one on the other aspect, I also learned from the student also, and from my faculties and mentors also. So happy Teachers Day on the same. So I'm presenting a case of 26-year-old male residing in the rural area, referred from the district level private hospital to our emergency department on 19th of August with an endotracheal tube in situ. He had been managed with antibiotic, anti-epileptics, mannitol, and intravenous fluid over there. As per the history given by the informant, who was the elder brother of that patient, told that patient had a nausea, vomiting, abdominal pain, and diarrhea since early morning between 4 to 5 a.m. Then he was managed at local clinic in his village. He improved. Gradually, but again he deteriorated and had abnormal body movements and altered mental status around 8 a.m. So they took him to nearby district level private hospital, where he was intubated under sedation around morning 9 a.m. and treatment given as I told before, and shifted to our hospital for further management around 4 p.m. in evening, almost 12 hours after the event. On primary survey at our hospital, his airway was secured with ET tube 7.5 centimeter fixed at 22 centimeter. His breathing, chest was rising symmetrically without use of accessory muscle, bilateral equal air entry without any abnormal sound. He was on volume control mode of ventilation without any spontaneous respiratory efforts. His respiratory rate was 16 and was generating tidal volume of 380 ml with on PEEP of 5 and control machine tidal volume of 420 ml and on the same rate of RR of 16 per minute. He was not given any sedative or paralytic agent in the form of infusion or injection at our hospital, and his SpO2 was 99 on FiO2 of 100%. Circulation, capillary refill time was less than 3 seconds, and pulse rate was around 102, and blood pressure was 156 by 100 on injection NORAD 4 by 550 strength 10 mic per minute infusion. On disability aspect, GCS was even M1 and pupil were dilated equal 3 mm fixed, not reacting to light, and his random blood glucose was 108. On environment and exposure, temperature was 98.3 with warm periphery and no external injury mark. On ample history, no known allergies, medication, past histories. Last meal was around 8 p.m. at night, and event occurred at early morning between 4 to 5 a.m. This is the video while he was presenting to our hospital. Was showing areflexia, atonia in the upper and lower limb. His pupil were fixed, dilated, not reacting to light, doll's eye absent. He was not taking any spontaneous breathing. So these were the finding while he was presenting to ER. So adjunct to primary survey, we have asked for the ECG was normal, X-ray also normal, was having Foley's 16 French in situ with 3-number Goodell airway in situ, and on the POCUS examination, it was also normal. On reassessment was same finding as previous. On secondary survey, head-to-toe examination, in CNS, GCS was even M1. Pupil were bilateral equal 3 mm fixed dilated, not reacting to light. Power was not accessible. Tone was atonic. Plantar bilateral mute. Dols absent. Absent gag reflex and no rigidity in both the axes. RS, CVS and per abdominal examination was normal, though we have not done the log roll. Adjunct to secondary survey, blood report from the outside hospital was apparently okay. HB was fair, 12.6, total count around 11,000 with almost normal range of differential count. Platelet was also normal. MP, malaria parasite was normal. Create was 0.86, SGPT 40, urine routine was normal, INR 1, TSH 1.3, potassium 4.1. We asked for the ABG was 7.3 pH, 7.34 pH, CO2 46, bicarb 19. Yes, Sandevan. प्रिंट नहीं हो रहा है क्या?
नहीं, वो पता है अंदर की जमा हो गया क्योंकि आप लोग
फुल नहीं रहा है, उसको स्विच हो गया आगे, या फिर फोटो मेरे को फोटो निकाल के दे दो, ऐसा चलेगा चलेगा. Bicarb was 19, O2 was 135 on Ambu. Electrolyte, we have also asked for the electrolyte, urine myoglobin, urine toxicology, urine porphobilinogen, porphyria, CT brain was, and MRI brain with cervical spine screening was normal, and also asked for the EMG, NCV and whole blood clotting time, which was normal. So in the case summary, young champ of rural area, background of acute abdominal pain, vomiting, diarrhea, followed by altered mental status and acute flaccid paralysis with biased signs of brain death, apparently normal blood reports and imaging. So what could be the differential diagnosis for this patient? So any participants, students were there? Hello? Hello? Hello?
No, hi, Dr. Rushi. I think Q&A will be coming in the last if there is anyone which comes up.
Oh, okay, yeah.
Sure.
Then, yeah. So our differential diagnosis in AFP with AMS, though hypoglycemia and hyponatremia was ruled out in our case, but in this context of scenario, we have to suspect GBS with type 2 respiratory failure due to CO2 retention, then OP poisoning, brainstem stroke, anoxic encephalopathy, neurotoxic snake bite, acute intermittent porphyria, Japanese encephalitis, autoimmune encephalitis, lead poisoning, and botulinism. So my questions are, which are the bias factor of brain death? Difference between the common Krait bite versus Cobra bite versus other, neurogenic shock versus spinal shock, and what is the final diagnosis as per the scenario. So the bias factor for the brain death in our majority of cases, we have to before stamping the brain death, we have to rule out the hypothermia, electrolyte disturbance, or endocrinal disturbance. Among endocrine, thyroid disturbance is the most common cause. CNS depression agent, sedative and hypnotic agents, muscle relaxant, anesthetic agent, alcohol and opioid consumption, paralytic agents, envenomation on toxin ingestion, severe hypotension, severe hypoxia, hypercarbia, and movement from the spinal cord like triple flexion or Lazarus sign. Immature nervous system in context of pediatric population, and post resuscitation brain suppression due to recent cardiac arrest are the most common bias factor for the brain death. For the common Krait and Cobra bite, the major difference is the common Krait is a neurotoxic, mainly presynaptic neurotoxin, while Cobra is a neurotoxin with cytotoxic snake bite. Time of bite is usually night, and Cobra generally bite at the daytime. Pain is less common or often unnoticed in the common Krait, while Cobra bite is painful. Rest difference are the minimal or no local swelling or inflammation at the bite site in the common Krait, but the abdominal pain, mild ptosis, malaise, rapidly progressive descending paralysis, ptosis, ophthalmoplegia, respiratory paralysis is the most common aspects in the Krait bite. While in the Cobra bite, pain, swelling, local tissue damage, and ptosis with neurological symptom, local pain and necrosis is the most common issue. Onset of symptoms are often इनको बोला निकाल दिया उससे, ठीक है चलेगा, उनको बोला नॉर्मल है. So symptoms of onset in the common Krait bite is often delayed 2 to 4 hours after the bite. And but in the Cobra bite, it is within 30 minutes to 2 hours. Autonomic symptoms are rare, and Cobra bite have autonomic symptoms are there. Among both have almost at par risk of mortality, and characteristic of clue, patient might not have a recall bite because it is painless and often at night, because common Krait is a very they love the heat of the human body, so they generally bite very painlessly, and often we unnoticed, and the bite mark are majority of time not present. Treatment is same for both the variety. Once a week and 2 times a day. हफ्ते में एक बार चूसने के लिए, और दिन में 2 टाइम. For the variety of snake bite, in the common Krait, neurotoxic presynaptic venom type is there. The symptoms are the progressive paralysis, respiratory failure, and type of shock is neurogenic shock. Cobra, neurogenic plus cytotoxic venom type, having a local necrosis with paralysis. Also, it is a neurogenic shock. Russell Viper, it is vasculotoxic or hemotoxic, having coagulopathy, DIC, AKI, but it's a hypovolemic shock. Sowjanya Viper, it's also vasculotoxic, hematotoxic, same profile as the Russell Viper. And sea snake is a myotoxic, plus or minus it is a neurotoxic. It causes rhabdomyolysis, myoglobinuria, paralysis, and it causes a hypovolemic shock. For the neurogenic versus spinal shock. So in the neurogenic shock, it is a hemodynamic phenomenon. While in the spinal shock, it is a loss of neurological activity in the form of motor, sensory, reflex, autonomic below the level of injury. Both having an immediate onset of injury, and the primary problem is circulatory failure in the neurogenic shock and the neurologic silence in the spinal shock. Clinical signs generally hypotension, bradycardia, having a warm, dry skin, poikilothermia, and in the spinal shock, it's a flaccid paralysis below the injury, areflexia. Duration is hour to week, and in the spinal, it is up to 24 hour, from 24 hour to several week it can occur. Key diagnostic feature is persistent bradycardia despite hypotension, distinguished from hypovolemic shock. And for the spinal shock, it's a return of bulbocavernous reflex signals and of spinal shock. So this is a very important finding. And for the treatment part, IV fluid, vasopressor, atropine for the severe bradycardia, and maintain the normothermia for the neurogenic shock. And while spinal shock needs supportive care, monitor neurological recovery. So our final diagnosis, which was clinical, was snake bite envenomation and was common Krait most likely. We have given the AN challenge test till ASV arranged, but no improvement after 3 repeated doses, so we have stopped. And then injection ASV 10 vial given. Further in the ICU, another 10 vial were given, and total 20 vial were given with supportive treatment. So on the day 2 of day 2 morning, this was the scenario. He was able to understand and try to answering. Yes, he was trying to follow the verbal command and try to open the eyes. And on the day 3, he was fully awake, opening the eyes. He was on the T-piece. So this was after giving 20 vials of ASV and on the day 3. So before this was the diagnostic challenge, I will say, because he met with the 2 physician at the village and also at the district level hospital, and they could not identify the scenario. And at our hospital, as a tertiary care level hospital, it's a crucial to diagnose very promptly before stamping that patient is having any signs of brain death or not. So according to STG, standard treatment guideline for the snake bite envenomation, Indian version, reassure the patient, because 70% of all snake bite are from non-venomous species. Approximately 50% are venomous, but venomous species result in the dry bite where no venom is injected. At the periphery level, majority of time we see that they immobilize the limb by applying the tonic weight or splint, wooden stick or anything, but they do not block the blood supply or ideally we should lie in this recovery position, prone on the left side 2 times. जमे पहला खाने से पहले जमे पहले आ जमे પછી આ જમે પહેલા 15 મિનિટ પહેલા in case of multiple ligature, all the ligature can be released in the emergency room except the most proximal one. Ideally should not be released until patient is under the medical care in the hospital and resuscitation facilities are available and antivenom treatment has been started. So this is the overview of all the snake bite, their presentation, how they behave, how they clinically present in our ED. So generally we are talking about the neuroparalytic snake bite. So in the Cobra and Krait bite, they have a ptosis, diplopia, dysarthria, dysphonia, dyspnea, dysphagia, and paralysis. So we can say 5D and 2P. Okay. But for the vasculotoxic, they have a hematological phenomenon in the form of bleeding to DIC and AKI in shock. So how we give AN challenge test? We took 0.6 mg of atropine followed by neostigmine of 1.5 mg IV state. In case of children, atropine 0.05 mg per kg followed by neostigmine 0.04 mg per kg IV. But for that, we have to also look for the bradycardia. You should not give neostigmine before atropine. Then repeat the neostigmine dose 0.5 mg with atropine over 30 minutes for 5 doses. Thereafter, taper the doses at consecutive 1 hour, 2 hour, 6 hour and 12 hour. Positive response is measured as 50% or more recovery of the ptosis in 1 hour. If no response after third dose, stop the AN challenge test. For the envenomation, in case of cobra bite, it can take hours to many hours to present signs and symptoms. Improvement by atropine neostigmine indicates the cobra bite. And a few Nilgiri Russell Viper improve with this regimen. If no regimen after 3 doses of AN challenge test within 1 hour, it indicates probable Krait bite. Krait affect presynaptic fibers because calcium acts as a neurotransmitter over there, and injection calcium gluconate. 10 ml IV in children 1 to 2 ml per kg, 1:1 dilution slowly over 5 to 10 minutes every 6 hourly and continue till neuroparalysis recovers, which may last for 5 to 7 days. Bilateral dilated, poorly or non-reacting pupil is not a sign of brain dead in alapid environment. This is the most important point. And early morning symptom of acute abdominal pain with or without neuroparalysis can be mistaken for the acute appendicitis, acute abdomen, stroke, GB syndrome, myasthenia gravis, and hysteria. Strong clinical suspicion and careful clinical examination can avoid not only costly and unnecessary investigations such as CT, MRI, conduction studies, CSF studies, also help in avoiding undue delay in initiation of specific treatment of ASV. And AN challenge test help to rule out myasthenia gravis. This 20-minute whole blood clotting time, we have to consider the most reliable test for the coagulation. It's a very basic test. We can perform at periphery also. For that, we have to take 2 ml of fresh venous blood and we have to place that blood into new, clean and dry glass test tube. Which and should be undisturbed for the 20 minutes at the ambient temperature. It should be undisturbed for the 20 minutes and gently tilted and should not be shaken. If vessel used for the test is not made of ordinary glass, or it has not been, it should not be cleaned with the detergent, because if it is a ordinary glass or it is washed with the detergent, it may not stimulate clotting of the blood sample. Because the surface activation of factor 11, the Hedgeman factor, will only activate if it is a non-washed with the detergent or it is not ordinary glass. And then if this has been done, then test will be invalid. We generally use lyophilized ASV, which is in the powder form, required only to be kept cool in the room temperature. But the liquid ASV, which need the cold chain and refrigeration to maintain the shelf life. The most important aspect: do not apply or inject anti-snake venom locally. The most important aspect: ASV cannot reverse the necrotic action of venom site on the tissue, reverse the local swelling, renal failure, coagulopathy, and presynaptic envenomation. Okay, so ASV can only neutralize the circulating venom. For neuroparalytic snakebite, 10 vial ASV state as an infusion over 30 minutes, followed by second dose of 10 vial after 1 hour if no improvement within first hour. For the vasculotoxic snakebite, there are 2 regimens. low dose and high dose low dose infusion therapy and high dose intermittent bolus therapy. Low dose infusion therapy has a 10 vial for Russell Viper or 6 vial for scale Viper as a state as an infusion over 30 minutes, followed by 2 vial every 6 hours as an infusion in 100 ml of normal saline till clotting time normalized or for 3 days, whichever is earlier. For the high dose intermittent bolus, 10 vial of polyvalent ASV state over 3 minutes as infusion, followed by 6 vial 6 hourly bolus therapy till clotting normalize and or local swelling subsides. Give 10 vial of ASV on arrival, and you can repeat 10 vial, but not more than 20 vials of ASV if it is a patient with the neuroparalytic envenomation. No further ASV and atropine neostigmine infusion is required, only to reverse the ptosis. If it is unclear snake venom or components or ASV that can cross placenta or not, so the safety regarding the in the pregnancy, it is still questionable, but to save the life of mother, it is with high risk consent we should give the ASV to save the life of mother. Snakes inject the same dose of venom into the children and adults, so there is no discrepancy of dose in the adult and children, but the dilution is different. So for the children, this liquid should be diluted in 5 to 10 ml per kg body weight of normal saline, and should be run in the bottle of 200 ml to avoid fluid overload. If in case of anaphylaxis phylactic reaction, first to stop the ASV, there is no need of a test dose for instilling the ASV before instilling the ASV. If there is any anaphylaxis, just stop the ASV, give the epinephrine in the standard dose as we give in the anaphylactic shock. So this was the presentation. If you want to search interesting cases, you can take a screen picture and you can follow on my YouTube and Instagram ID. Thank you so much.
Thank you, Dr. Rushi. That was lovely. Thanks for the wonderful enlightening session. I think since we don't have any other Q&A, I think we'll be concluding with this. Okay. Thank you so much, Dr. Rushi.
Yeah, thank you so much.
Thank you.
Hope you